Today we are tackling a really huge topic. We're taking the densest, most complex realms of science, stacking up the source material, in this case, a deep pharmacological text, and trying to extract the essential knowledge you need to be truly informed.
And today, we're attempting to tame the immune system. We're wading right into the world of immunosuppressant drugs. These are the molecules that fundamentally reroute the body's, ancient, powerful defense mechanisms.
Right.
This isn't just about medicine. It's about the literal art of dialing down the immune system to save a life or manage a chronic disease.
Dialing down is absolutely the operative phrase. The immune system is, think of it like a perfect internal surveillance state. It's designed to eliminate anything foreign.
Anything.
Whether it's a virus, a bacteria, or a newly transplanted heart. So our mission today is to understand the chemical and biological blueprints these drugs use to convince the immune system to stand down, or at least look the other way.
Precisely. And our focus will be twofold. First, the major use in organ transplantation. That's really the primary historical driver for this whole class of drugs.
Okay.
And second, their increasingly sophisticated role in managing severe autoimmune diseases. We need to categorize the major groups, of course, but I think more importantly, we need to understand the how.
The mechanism.
Exactly. Knowing that a drug works is one thing. Understanding the exact molecular choke point it exploits. That's the key insight we're looking for today.
So to give you a map before we get lost in the weeds of T-cell pathways, our source material really helps us out. It categorizes this massive field into 5 major groups, and it's all based on their primary mechanism of attack.
And that roadmap is critical for context. It helps make sense of everything. So first, we have the calcineurin inhibitors.
Like cyclosporine, tacrolimus.
Right, the ones that stop the initial T-cell ignition. Second, the mTOR inhibitors, like sirolimus, which block the subsequent acceleration of that T-cell.
Okay, so a later step.
A later step. Third, you've got the broader anti-proliferative drugs like azathioprine and MMF, which just prevent the immune cells from multiplying.
More of a blanket approach.
A bit, yes. Then fourth, the universal suppressants, the glucocorticoids, think prednisolone. And finally, the really cutting-edge, highly specific biological agents, which are your antibodies and cytokine blockers.
That is our territory. And I think we have to start with the true revolution in this space. The drugs that turned organ transplantation from, a theoretical possibility into a clinical reality.
Oh, absolutely. The calcineurin inhibitors.
Let's dive in.
The breakthrough that the calcineurin inhibitors, specifically cyclosporine and tacrolimus, provided, it really just cannot be overstated. Before they arrived, transplant success rates were abysmal.
And the only option was just brute force.
Brute force chemotherapy, which killed everything indiscriminately. It was a terrible approach.
So let's focus on cyclosporine first, the pioneer. It was introduced in 1977. Tell us about its origin, because it's a surprising fact that brings a little bit of texture to this otherwise very dense topic.
It is a remarkable story of serendipity, really. Cyclosporine is a natural product. It was isolated from a fungus Polypocladium inflatum, which was found in a soil sample.
A soil sample?
A soil sample collected on a ski trip in Norway, of all places. It's a cyclic polypeptide. And its historical impact stemmed from its selectivity. It was the first drug that could effectively prevent graft rejection by specifically targeting the T-cell response without just wiping out the entire immune system.
Which was the standard approach until then.
It was. This was a game changer.
Okay, let's unpack this mechanism, because this is where we transition from history to true molecular engineering. If the T-cell is a missile, the goal here is to stop the launch sequence. But that activation sequence is incredibly complex. How does this fungal molecule, cyclosporine, manage to find the single most important choke point in that T-cell activation pathway?
Well, to understand the choke point, you need to picture the T-cell activation sequence as like a necessary ignition circuit. When a helper T-cell encounters a foreign antigen, let's say a protein, from a newly transplanted liver, it receives a signal.
Right.
This kicks off a really complex intracellular cascade. Now, we don't need to get into the details of PLC and PIP2 for this deep dive, but the result is what's crucial. And the result is a massive spike in intracellular calcium concentration.
So that calcium spike is the signal. It's the cell shouting, "We have contact. Initiate the response."
Exactly. That calcium spike then activates a key enzyme, a membrane-associated seronephranon phosphatase known as calcineurin. If you think of the whole activation pathway as a series of dominoes, calcineurin is the big domino that, when it's tipped, releases the major proliferation signal.
So calcineurin is the central amplifier. What is its normal job inside a healthy, active T cell?
Calcineurin's job is to target another key regulatory protein. This one is called nuclear factor of activated T cell, or NFAT.
NFAT, let's just call it the go signal protein, makes it easier.
The go signal protein, I like that. So NFAT normally just sits in the cytoplasm in a phosphorylated state, which means it's inactive.
It has a safety on it.
Exactly. Calcineurin, once it's activated by all that calcium, rushes in and it dephosphorylates NFAT. It essentially strips off that inhibiting phosphate group, flicks the safety off.
And once NFTB is naked and activated, it gets its travel papers to go to the nucleus.
Precisely. Once dephosphorylated by calcineurin, NFA is permitted to migrate from the cytoplasm across the nuclear membrane and right into the nucleus. And once it's in there, it acts as a transcription factor. It drives the massive transcription of critical cytokine genes. The most famous one, of course, being interleukin-2, or IL-2.
And IL-2 is the T cell's primary multiplication signal. It's the order that tells the cell, divide immediately, call for backup, along with other inflammatory signals like GM-CSF and interferon.
That's the entire response system in a nutshell. Now here's where cyclosporine, our fungal product, steps in as the molecular assassin. Cyclosporine is a small molecule. It gets into the T cell, but it doesn't target calcineurin directly. This is the cool part. Instead, it finds a specific intracellular protein called cyclophilin. It's a type of immunophilin, and it binds to that first.
So it needs a chaperone to do its dirty work.
It does. A molecular chaperone is the perfect analogy. The moment cyclosporin is bound to cyclophilin, this new complex, it's now the perfectly shaped molecular key to find and inactivate the calcineurin enzyme. It just slots in and blocks its active site.
So by blocking calcineurin, that crucial dephosphorylation step never happens. NFAK, the go signal protein, it just remains stuck in the cytoplasm, and the T cell never gets the memo to start transcribing the IL-2 proliferation signal. It's arrested immediately.
Exactly. The T cell is effectively stopped in its tracks. It's arrested in the G0 or G1 phase of the cell cycle, which means it can't divide, it can't progress toward differentiation. And what's so remarkable about this discovery is how surgical it was compared to everything that came before. Our source material really highlights that cyclosporine is selective enough that it has no observed effect on the activity of suppressor T cells, which is crucial for maintaining overall immune balance. It targets that helper T cell response specifically.
And that selectivity is what enabled the entire age of modern transplantation.
Yeah.
Now, in terms of clinical applications, we know the primary use is preventing graft rejection, but cyclosporine has also been a powerful tool in autoimmune disorders.
Oh, absolutely. It's often used as a second-line treatment for severe, debilitating autoimmune conditions. I mean, think of severe rheumatoid arthritis, uveitis, inflammatory bowel disease, or even acute flare-ups of psoriasis.
And the dosing is different for those, I imagine.
Yes, the doses used for these long-term maintenance applications are generally lower than what you'd need for transplant prophylaxis, which of course helps manage that side effect burden. The general strategy is to withdraw the drug once the patient achieves remission.
Now, let's talk logistics. Cyclosporine sounds like a miracle drug, but administering it, from what I've read, it sounds like a nightmare because of the pharmacokinetics. Why is monitoring so challenging?
It is intensely complicated, and this is a massive limiting factor for the drug. The key problem is its highly variable oral bioavailability.
So how much of the drug actually gets absorbed?
Right. It's highly lipid soluble, and its absorption is heavily dependent on the presence of bile. This means that a patient's diet, any concurrent illnesses they have, and especially their liver health, can drastically change how much of the drug actually reaches the bloodstream.
And with a narrow therapeutic window, the margin between an effective dose and a toxic dose, that variability is terrifying.
It is, and it necessitates rigorous therapeutic drug level monitoring, or TDM. Physicians have to constantly monitor blood levels to ensure the patient is in that effective but non-toxic sweet spot. And to make it even more complicated, cyclosporine is metabolized in the liver by the notorious CYP3A4 enzyme.
Ah, the CYP3A4 flag. That is the enzyme that's responsible for metabolizing maybe half of all drugs on the market.
Right.
So that means drug interactions aren't just possible. They're guaranteed to be a clinical reality.
Massively so. You have to be meticulous. If a patient takes a drug that inhibits CYP3A4, like the antibiotic erythromycin or the antifungal ketoconazole, the breakdown of cyclosporine slows down dramatically,
Leading to toxic accumulation.
one potentially kidney failure. Conversely, if they take a drug that induces CYP3A4, like certain anticonvulsants, phenobarbital, or the anti-TB drug rifampin cyclosporine is broken down too quickly, and the graft rejection protection is just lost.
And for a touch of real-world texture, our source explicitly mentions a common food interaction that must be monitored.
Yes, the infamous grapefruit juice interaction. It sounds like a myth, but it's very real. Grapefruit juice is a well-known potent inhibitor of CYP3A4. A simple glass of juice could significantly boost the cyclosporine level right into the toxic range, causing severe nephrotoxicity.
Wow.
It just highlights how delicate this pharmacological balance really is.
It sounds like a full-time job just to manage cyclosporine. This brings us to its potent successor, tacrolimus. If cyclosporine was the breakthrough, what refinement did tacrolimus bring to the table?
Tacrolimus, or FK506, is chemically distinct. It's a macrolide, not a cyclic polypeptide like cyclosporine, but it operates using the exact same core mechanism, calcineurin inhibition. The key refinement is really twofold: potency and pharmacokinetics.
Okay, let's start with potency.
Tacrolimus is exponentially more potent. We're talking 10 to 100 times more effective than cyclosporine.
That's a huge difference.
It's massive. And mechanistically, it binds to a different immunophilin, the FKBP, that's FK506 binding protein, but the outcome is the same. The FKBP tacrolimus complex binds to and inactivates calcineurin. It hits the exact same choke point, just via a different molecular handle.
So same target, different key, much higher firepower. What about the pharmacokinetic improvement you mentioned?
The absorption of tacrolimus is much less dependent on bile. And while it's still metabolized by CYP3A4 and requires that same therapeutic drug monitoring, its overall oral bioavailability is more consistent and predictable.
Which makes daily dosing a bit easier to manage.
Exactly, especially in fields like liver transplantation, where bile flow can be erratic and unpredictable.
So the key clinical dilemma for a physician isn't about which mechanism to use, since they're the same, but which set of side effects to accept. If tacrolimus is so much more potent and often easier to dose, why would cyclosporine ever still be the first choice?
That is the essential trade-off, and it comes down entirely to the adverse effects. The major limitation shared by both of the calcineurin inhibitors is severe nephrotoxicity. They damage the kidneys.
Which is the organ you're often trying to save.
Precisely. This often leads to chronic renal failure, complicating the very procedure they are meant to support. They also both increase the risks of hypertension and inducing new-onset post-transplant diabetes mellitus or NODAT.
But they each have their own unique signature side effects, right?
They do. Cyclosporine is famous for its cosmetic and mild neurological effects. You have hirsutism, which is excessive hair growth, and gum hyperplasia, which is an overgrowth of gum tissue. These are often cosmetically unacceptable to patients and can be a real problem.
And tacrolimus.
Tacrolimus, conversely, generally has a lower risk of those specific cosmetic issues, which is a major benefit for many people. However, and this is a big however, tacrolimus carries a significantly higher risk of neurotoxicity.
What does it look like?
Tremors, headaches, and sometimes even seizures. It also potentially has a higher risk of causing that new onset diabetes.
So the choice might be, do we risk cosmetic issues and manageable tremors, or do we opt for the more potent drug with a higher neurotoxicity and diabetes risk? It's a very careful, personalized risk assessment for every single patient.
It is. It's a lifelong calculation where the side effect profile often dictates the choice, even given tacrolimus's superior potency. Both are foundational drugs, but the physician is always aiming for the lowest possible dose of either one to limit that devastating nephrotoxicity.
That intensive look at calcineurin inhibitors really establishes the primary mechanism for blocking T-cell activation. So now let's move to the next generation, the MTOR inhibitors sirolimus, everolimus, and temsirolimus, which target a later stage, acting as a critical safety net.
This is a perfect example of how targeted pharmacology refines the process over time. Sirolimus, which is also known as rapamycin, is the prototype for this class. And it has another interesting origin story.
Oh.
It was isolated from a bacteria, Streptomyces hygroscopicus, that was found in a soil sample from Easter Island,
Rapa Nui.
Rapa Nui, hence the name rapamycin.
What's the mechanical distinction here? Where does sirolimus fit into that T-cell ignition story we were just building?
Okay, so here's the real aha moment of this entire class because it connects directly back to what we just discussed. Sirolimus is also a macrolide, just like tacrolimus, and it binds to the exact same intracellular protein, the FKBP immunophilin.
Wait, hold on. So two chemically distinct drugs, tacrolimus and sirolimus, both bind to the same protein, FKBP. But you said the tacrolimus FKBP complex block calcineurin. Our source says the sirolimus FKBP complex does not inhibit calcineurin. That's astonishing molecular specificity.
It truly is. It's a beautiful demonstration that the shape of the resulting complex is what dictates the target. So instead of going after calcineurin, the sirolimus FKBP complex targets the mammalian target of rapamycin kinase, or mTOR.
mTOR, let's translate that into our ignition analogy. If calcineurin inhibition prevents the T cell from even generating the IL-2 signal, what is mTOR's role?
mTOR is the main cellular regulator of proliferation, growth, and survival. It's a vital downstream link in the signaling cascade that's triggered by IL-2. Remember we said IL-2 tells the cell to multiply? Well, mTOR is essentially the cell's accelerator pedal for that growth and division.
So if cyclosporine or tacrolimus fail and some IL-2 is generated and gets through, sirolimus steps in to prevent the cell from actually responding to that IL-2 signal.
Exactly. It blocks T-cell proliferation and differentiation at the next stage. Specifically, it arrests the T-cells between the G1 phase, which is the growth phase, and the S phase, the DNA synthesis phase. It stops the cell right before it can duplicate its genetic material and divide.
This makes the combination of a calcineurin inhibitor and an mTOR inhibitor a very attractive strategy. You're hitting the system at two separate critical points.
It's the ultimate 1-2 punch. Sirolimus is used for prophylaxis of graft rejection, and it's often specifically designed to be combined with a calcineurin inhibitor and corticosteroids. And crucially, because its mechanism bypasses calcineurin entirely, it provides a powerful route to immunosuppression that is non-nephrotoxic.
And that's a huge advantage.
A huge advantage in patients who are struggling with cyclosporine or tacrolimus-induced kidney damage.
The anti-proliferative nature of sirolimus is so powerful that it's leveraged in a really specific non-transplant application that I find incredibly insightful.
Yes, this is where the mechanism just comes to life. Sirolimus-coated stents are now a mainstay in interventional cardiology. They're used to prevent coronary artery restenosis.
So narrowing of the artery again.
Right. When a stent is placed to open a blocked artery, the body's natural healing mechanism involves the proliferation of endothelial and smooth muscle cells, which can cause that artery to narrow again. That's restenosis.
So by coating this stent with sirolimus, you are essentially administering a microscopic, localized immunosuppressant right where you need it.
You are inhibiting localized cell growth. The drug slowly seeps into the arterial wall and prevents that G1 to S transition in those cells, stopping the localized proliferation that would cause the restenosis. It's the same anti-growth mechanism we use against T cells, but it's been repurposed to keep an artery open.
That is a remarkable demonstration of how this pharmacological principle can be applied. But what are the costs? What are the side effects associated with stopping cell growth so broadly throughout the body?
Since the anti-proliferative effect is systemic, the side effect profile is significant. Patients frequently suffer from severe hyperlipidemia, that's high cholesterol and triglycerides, and also significant bone marrow suppression.
Which would lead to things like low platelet counts.
Exactly, often thrombocytopenia. Furthermore, sirolimus is notorious for impairing wound healing, which makes its use immediately post-surgery or in liver transplants, where absorption is already poor, very problematic. It also carries risks of pneumonitis and hepatotoxicity.
And just like the calcineurin inhibitors, sirolimus is also extensively metabolized by CYP3A4, which means all the same drug interaction concerns apply, compounded by a very long half-life of 60 hours.
That long half-life makes TDM crucial once again. Now, a brief mention of its congeners, everolimus and temsirolimus, really shows how pharmaceutical development aims for optimized handling of these molecules.
So what did those tweaks achieve?
Well, everolimus has a shorter half-life, around 40 hours, which can be advantageous for making faster adjustments to the dose. It's used in renal transplant, but also, crucially, in oncology for advanced breast cancer and neuroendocrine tumors.
So we see the immunosuppressant being repurposed as an outright anti-cancer agent.
It's the logical extension of the mechanism. If it stops immune cells from proliferating, it can stop cancer cells from proliferating. And temsirolimus is water-soluble, it's administered intravenously, and it's indicated specifically for certain forms of cancer, like mantle cell lymphoma. These variations maintain that core MTO target, but they optimize the drug's delivery or half-life for highly specialized clinical niches.
We've covered the highly specific inhibitors that block signaling pathways. Now let's pivot to the older, broader, but still essential cytotoxic and anti-proliferative drugs. These don't target one specific enzyme. They stop cells from dividing by interfering with fundamental DNA processes.
Right, these drugs were the original workhorses of immunosuppression. They function by essentially poisoning the replication machinery of rapidly dividing cells. And since lymphocytes, both T and B cells, are some of the most proliferative cells during an immune response, they get hit particularly hard.
Let's start with azathioprine. It's still a staple in many maintenance regimens.
It is. Azathioprine is a purine antimetabolite. It's actually a prodrug that gets converted in the body into 6-mercaptopurine. Once it's activated, its metabolites are incorporated directly into the DNA and RNA of dividing immune cells.
So it creates faulty building blocks.
Exactly. It leads to inhibition of T-cell differentiation and outright cytotoxic injury to the lymphocytes. It just kills them.
That sounds like a much less selective method than blocking something like calcineurin.
It is much less selective, which is why it comes with broader side effects, but it is highly effective at keeping the overall population of reactive immune cells low. It's primarily used in maintenance regimens for renal transplant and often used long-term in autoimmune diseases like rheumatoid arthritis and chronic active hepatitis. Its advantage is its long history of efficacy and, frankly, its relatively lower cost compared to the newer biologics.
Next up, methotrexate, or MTX, which is ubiquitous in autoimmune management, especially for rheumatoid arthritis.
Methotrexate is a classic folic acid antagonist. Folate is crucial for the synthesis of precursors needed for DNA and RNA. By antagonizing the necessary enzymes, MTX effectively starves rapidly dividing cells, including immune cells, of these essential building blocks.
So a different way of stopping DNA synthesis.
Yes. It's an incredibly powerful immunosuppressant, and it's considered first-line therapy for the management of rheumatoid arthritis, psoriasis, and many other systemic inflammatory disorders. Its mechanism is proven, but its use requires very careful monitoring for liver toxicity.
Then we arrive at mycophenolate mofetil, or MMF, which our source says has largely replaced azathioprine as the preferred anti-proliferative agent in many contemporary transplant regimens.
MMF is a critical drug because it sort of bridges the gap between the blunt cytotoxic agents and the highly specific inhibitors we've been talking about. MMF is a prodrug that inhibits an enzyme called inosine monophosphate dehydrogenase, or IMPD. This enzyme is essential for the de novo synthesis pathway of guanosine nucleotides.
Okay, so why is targeting IMPD so selective for lymphocytes? Why doesn't it affect all cells?
This is the key functional detail. Unlike most other cell types in the body, which can use salvage pathways to acquire their nucleotides, lymphocytes, both T and B cells, rely almost exclusively on this de novo synthesis pathway when they need to proliferate rapidly.
Ah, so you're exploiting a unique dependency of the immune cells.
Exactly. By blocking IMPD, MMF essentially starves the lymphocytes of the guanosine they need to divide and respond to a threat. It doesn't affect other cells nearly as much.
So it achieves a high degree of functional selectivity without relying on the physical mechanism of a T-cell receptor.
Precisely. It achieves a selective arrest of lymphocyte proliferation and differentiation, which makes it incredibly effective in combination therapies. Our source material highlights the strategic use of MMF. For example, the combination of MMF plus a glucocorticoid plus sirolimus offers a powerful, modern, and highly sought-after non-nephrotoxic triple regimen,
which allows clinicians to potentially minimize or even eliminate the use of those kidney-damaging calcineurin inhibitors.
That's the goal. It's a huge step forward.
But every drug comes with a compromise.
Yeah.
What is the major limitation of MMF?
The most common side effects are gastrointestinal. We're talking nausea, vomiting, and severe diarrhea, which can really affect patient compliance. But more critically, MMF is a known teratogen and is absolutely contraindicated during pregnancy due to a very high risk of birth defects.
Finally, we cannot discuss immunosuppression without talking about the steroids. Glucocorticoids like prednisolone. These are the broad-spectrum heavy hitters.
Glucocorticoids are indispensable. They're in a class of their own because they combine profound immunosuppressive activity with powerful anti-inflammatory effects. Their mechanism is vast. They inhibit the expression of MHC antigens, they turn down the production of key cytokines like IL-1 and IL-2, they disrupt cell adhesion molecules
And they work incredibly fast.
instantly. They cause a rapid reduction in the circulating T lymphocyte mass. Now, this happens partly by inducing apoptosis, which is programmed cell death, but largely by causing redistribution.
What does that mean?
It means they sequester the lymphocytes away from the bloodstream and into lymphatic tissues. They temporarily remove the soldiers from the battlefield, which is incredibly useful in an acute situation.
Therefore, they are perfectly suited for crisis management.
Exactly. They are used in very large high-dose pulses for short periods, either to manage an acute graft rejection or to suppress a severe acute flare-up of an autoimmune disease. They are a necessary component in almost every induction and maintenance regimen because of that ability to suppress the initial cytokine storm.
But this power comes with perhaps the steepest long-term price tag of any class we discussed today.
Undeniably. While they are essential for short-term control, the limitations of long-term use are severe and systemic. Chronic use leads to debilitating side effects: osteoporosis, Cushing's syndrome, mood disturbances, high blood pressure, fluid retention, a high susceptibility to infection, and steroid-induced diabetes. The goal in maintenance therapy is always to use the absolute minimum dose necessary or phase them out entirely if you can, because of these predictable chronic toxicities.
Now we are in the modern era. We've gone from broad-spectrum DNA poisons to enzyme inhibitors, and now we move to biologics. These are large molecules engineered to hit a very specific receptor, like a sniper rifle, versus the broad artillery we've been discussing so far.
The biological agents are recombinant proteins, or monoclonal and polyclonal antibodies, and their advantage is precision. They are designed to act on a singular target, which leads to fewer systemic side effects, at least in theory, though they are often used as supplementary or rescue drugs due to their complexity and cost.
Let's start with the TNF inhibitors. If someone has severe autoimmune inflammation, this is often the first drug class they think of these days.
Absolutely. Tumor necrosis factor alpha, or TNF, is a master cytokine. It's a central signaling molecule released primarily by activated macrophages. It promotes, it sustains, and it amplifies the entire inflammatory cascade, which is what leads to joint destruction in rheumatoid arthritis or gut inflammation in Crohn's disease.
So the TNF inhibitors etanercept, infliximab, adalimumab work by neutralizing this one cytokine.
Yes, and they do it in two main ways. Drugs like adalimumab are monoclonal antibodies that bind directly to circulating TNF, essentially scooping it out of the system so it can't bind to its receptors.
Okay.
Etanercept is a little different. It's a fusion protein that mimics the TNF receptor. It acts as a decoy receptor that soaks up all the TNF, rendering it inactive. By removing the central inflammatory driver, they can dramatically halt the progression of autoimmune diseases like severe RA, Crohn's, and psoriatic arthritis.
This sounds like a much cleaner way to stop inflammation than dumping high-dose steroids into the system.
It is, which is why their use has completely revolutionized autoimmune care. But we still need to be aware that even this targeted approach carries that universal risk of immunosuppression. There's an increased infection risk, particularly for tuberculosis, as TNF is key to walling off TB infections in the body.
Next, let's look at the interleukin, or IL, antagonists, which target specific signaling molecules needed for T-cell communication.
The IL antagonists are highly strategic. First, we have anakinra, which is an IL-1 receptor antagonist. It's a recombinant version of the human IL-1 receptor. It works by blocking IL-1, which is key in activating helper T cells and driving fever and inflammation. It's mainly used in specific types of RA and certain inflammatory syndromes.
And what about the most important target for transplantation induction, the IL-2 receptor?
Absolutely. The IL-2 receptor has a specific subunit called CD25 that is only highly expressed on T cells after they have been activated by an antigen. This makes it an ideal, specific target for preventing acute rejection.
Why? What makes that so ideal?
Because you are only targeting the T cells that have already been exposed to the graft's foreign antigens. You're not touching the rest of the immune system. This allows the bulk of the quiescent immune system to remain untouched. So drugs like basiliximab and daclizumab are chimeric monoclonal antibodies that specifically bind to CD25.
They essentially put a muzzle on the activated T cell, preventing it from responding to its own multiplication signal from IL-2.
That's it exactly. They are primarily used in renal transplant induction regimens. Often it's just 2 doses, combined with the calcineurin inhibitors and antiproliferatives. Their use allows the initial dose of the nephrotoxic CIs to be kept very low, which mitigates early kidney damage, a major strategic advantage.
Finally, let's look at the actual anti-T cell antibodies, which are designed to actively remove the immune cells from circulation. We have the specific monoclonal approach and the broader polyclonal approach.
And we must contrast miromonab CD3 with antithymocyte globulin, or ATG. Miromonab CD3 is a murine-so mouse-derived monoclonal antibody. It binds directly to the CD3 antigen, which is an integral part of the T-cell receptor complex.
By binding CD3, what is the consequence? What does that do?
It achieves two things. First, it physically blocks the T-cell from recognizing the antigen MHC complex, stopping activation cold. Second, it tags the T-cell for destruction, leading to the rapid depletion of T-cells from the circulation. It is typically reserved for aggressive acute rejection rescue therapy.
But since it is a mouse-derived protein, there is a risk of a severe reaction from the patient's body.
A huge risk. The body recognizes it as foreign, and this can lead to the infamous cytokine release syndrome upon first administration. You see high fever, chills, wheezing, nausea, sometimes hypotension. It's a severe reaction, but often a necessary intervention to save the graft.
Compare that to the polyclonal approach, ATG.
ATG is the sledgehammer. It's polyclonal, derived from the serum of horses or rabbits that have been immunized with human lymphocytes. Therefore, the resulting serum contains high titers of antibodies against many different human lymphocyte antigens, T cells, B cells, NK cells, even HLAs.
So ATG throws a very wide net and depletes the entire T cell and B cell population, whereas miromonab CD3 targets one specific T cell marker.
Exactly. ATG causes profound and generalized lymphocyte depletion. It is used for steroid-resistant acute rejection episodes when the patient's life or the organ is immediately threatened. It is the ultimate rescue therapy.
Before we move on to the regimens, quickly, let's mention the crucial use of anti-immune globulin in maternal fetal medicine. It's the different application.
It is. This is a specific example of utilizing antibodies for immune prevention rather than suppression of an ongoing attack. Anti-immune globulin, also known as RhoGAM, contains human IgG antibodies against the Rh-positive red blood cell antigen. It's administered to Rh-negative mothers who may have been exposed to Rh-positive fetal blood during delivery or an abortion. The antibodies bind to any of those fetal Rh-positive cells in the mother's circulation, masking them before the mother's immune system can recognize them and develop her own permanent antibodies. This prevents future severe complications like Rh hemolytic disease of the newborn. It is a critical life-saving intervention.
We've established the specific functions and the side effect profiles of 5 distinct drug classes. Now, the true artistry of medicine comes in combining them. How do physicians strategically use these potent drugs to manage a transplant across the lifespan of the organ?
We break the strategy down into 3 sequential pillars, each with a different tactical objective: induction, maintenance, and rescue. The key is understanding that we use combinations to maximize efficacy while minimizing the dose of any single toxic drug.
Let's start with the induction regimen. This is the immediate perioperative strategy right at the time of the transplant.
Induction is absolutely critical. It's the period immediately surrounding the transplant from just before surgery up to about 3 months afterward. The goal is overwhelming: immediate suppression to prevent the initial, violent, acute T-cell response to the foreign graft.
So what are the components?
The components are high doses of the core drugs: a calcineurin inhibitor, usually tacrolimus for its better dosing profile, prednisolone, and an anti-proliferative agent like MMF.
And this is where the biologics are strategically deployed to hit that initial response hard.
Yes, this is where they shine. Induction protocols often include powerful biological agents. We are talking about T-cell depleting agents like ATG or the IL-2 receptor blockers like basiliximab. The strategic genius here, especially in renal transplants, is to use the powerful biologicals to achieve T-cell depletion and strong initial suppression, which then permits the physician to start the highly nephrotoxic calcineurin inhibitors at a much lower initial dose.
Or even delay them entirely.
This saves the new kidney from early permanent CI-induced damage.
Once that initial high-risk period is passed, the patient transitions to the second and most prolonged phase: maintenance.
Maintenance is the long game. It's lifelong in most cases. The goal here shifts to preventing chronic rejection, which is often a slower, harder-to-treat process, while simultaneously mitigating the long-term systemic toxicity associated with these powerful drugs.
So what does a standard contemporary maintenance regimen look like?
It is typically a triple drug regimen. The standard template is one calcineurin inhibitor tacrolimus is often favored, a lower dose of a corticosteroid like prednisolone, often with the goal of tapering it off completely, and an antiproliferative agent.
And MMF is usually the choice there.
MMS is generally the preference over azathioprine due to its more selective mechanism. The specific combination, however, is constantly being adjusted based on the patient's response and side effects.
So they're constantly performing that balancing act. Enough suppression to hold off chronic rejection, but not so much that the patient develops debilitating long-term side effects like osteoporosis or uncontrolled hypertension.
It is personalized medicine in its purest form. Some patients transition to dual therapy, dropping prednisolone completely. Or sometimes even cautiously dropping the calcineurin inhibitor after a year if they are stable and switching to an MMF and sirolimus combination, aiming for that non-nephrotoxic benefit. But any reduction in the drug load carries the inherent risk of rejection, so it is a perpetual, cautious negotiation.
And finally, the third pillar, the anti-rejection or rescue regimen. This is the emergency plan for when the maintenance regimen fails and acute rejection rears its head.
Right. Acute rejection is usually a rapid T-cell attack, and it often occurs in the first year after transplant. The first line of defense is aggressive and high impact, a high-dose steroid pulse. Typically methylprednisolone administered intravenously for 3 to 5 days.
And that usually works.
Because glucocorticoids redistribute T cells and suppress that acute cytokine rush so effectively, this resolves the rejection in the majority of cases.
And if that steroid pulse fails, we pull out the heavy artillery.
Then we move straight to antibody-based rescue therapy. This means deploying the potent T-cell depleting agents we discussed, either miromonab CD3 or antithymocyte globulin, ATG, depending on the specific protocol and organ. These are used in conjunction with steroids and possibly an increase in the maintenance drug doses to aggressively reverse the immune attack and salvage the threatened organ. Failure to reverse acute rejection means the transplant will fail.
Which is the ultimate clinical catastrophe.
It is.
This entire system, this triple pillar approach, it really showcases how physicians exploit the different mechanisms of action. The initial signal block from CIs, the response block from MTOR, the proliferation block from MMF, and the generalized inflammation stop from steroids to create these layers of protection.
It is complex pharmacological orchestration. It demands constant surveillance because the stakes are always, always life and death.
So if we synthesize this immense amount of information, what's the core truth that emerges?
The core truth of immunosuppressive therapy is that these drugs are necessary, powerful shortcuts. They circumvent evolution and allow the human body to accept a foreign object. They are the reason organ transplantation is possible.
But, as you pointed out, every step of the way, this acceptance comes at a severe systemic cost that unifies every single class, from the fungal-derived cyclosporin to the newest monoclonal antibodies.
And we must reiterate that cost clearly for you, the learner. The two overarching, inescapable vulnerabilities created by dialing down the immune system are, first, a dramatically increased risk of severe opportunistic infections.
Bacterial, fungal.
Bacterial, fungal, and viral. Our sources highlight that viral infections, particularly cytomegalovirus, CMV, and Epstein-Barr virus, EBV, are a continuous threat that must be actively monitored and treated.
And the second major risk involves long-term vulnerabilities.
The second risk is the increased incidence of lymphomas and other related malignancies. The immune system maintains a crucial function called immune surveillance, constantly identifying and eliminating cancer cells and virally transformed cells before they can establish a foothold.
And when we suppress the immune system,
we weaken this surveillance. We open the door for malignancies to develop, which is a tragic and, for now, unavoidable consequence of successful transplantation.
So what does this all mean for the future, especially for you, the learner, considering how rapidly pharmacology is advancing? The current generation of drugs performs miracles, but it forces this high systemic trade-off between fighting graft rejection and fighting cancer or infection.
That is the ultimate profound challenge posed by this entire field. If broad suppression leads to secondary cancers and overwhelming infections, what does the rise of these highly specific, highly targeted biological agents, like the IL-2 receptor antagonists and the TNF-A inhibitors, imply for the next wave of research?
Could we eventually develop a drug combination that is so precise, perhaps only binding to the exact T-cell clones that recognize the foreign graft, that it provides powerful anti-rejection therapy while leaving the crucial anti-cancer and antiviral functions of the remaining immune system entirely intact?
That is the aspiration. That is the holy grail. To move beyond broad immunosuppression toward truly surgical, safe immunomodulation, where the patient maintains transplant function but enjoys the robust health of a fully functioning immune system. That challenge will define the next generation of pharmacology.
A truly challenging and profound concept to mull over. Thank you for taking this very deep dive with us today.
Until the next deep dive.